President, Vice President, members of Council, past President, fellows, members, affiliated members, distinguished guests, and particularly tonight's Millin lecturer, Professor Jarlath Bolger, and it's a great pleasure to welcome his family to RCSI in this special occasion, the 48th Annual Millin Lecture. It gives me great pleasure to invite the President of the Royal College of Surgeons in Ireland, Professor Deborah McNamara, to come forward to introduce Professor Jarlath Bolger, our 48th Millin Lecturer.
Past President, Vice President, members of Council, Vice-Chancellor, fellows, members, affiliate members, distinguished guests and colleagues, ladies and gentlemen. It's a great pleasure to welcome each of you to RCSI this evening for the 48th Millin Lecture. My name is Professor Debbie McNamara and I'm President of RCSI. I'd like to particularly welcome our 2025 Millin Lecturer, Professor Jarlath Bolger, and his family here this evening. We're joined here by his mother Bridget, his wife Dr. Marie Bambrick, his parents-in-law John and Mairead, and his children Elliot and Hannah. You are each so welcome. It's also a great pleasure to be joined by so many of his colleagues from Beaumont Hospital and his research collaborators. This lecture is held in memory of Irish urologist Terence J. Millin, who died in 1980. As well as being past president of RCSI, Millin was a pioneer in prostate surgery and published an original description of the Millin retropubic prostatectomy in The Lancet. The Millin Lecture is a very special event on the RCSI calendar, celebrating as it does some of the most accomplished young surgeons of each generation, and this year's lecturer is no exception. Professor Jarlath Bolger is a consultant general and esophagogastric surgeon at Beaumont Hospital, an associate professor of surgery at the RCSI University of Medicine and Health Sciences. He qualified from RCSI with honours in 2009, achieving the J.J. Fitzsimons Gold Medal in Surgery. Having completed his internship at Beaumont Hospital in 2010, he immediately embarked on a PhD on the subject of endocrine-resistant breast cancer and its mechanisms for metastasis under the supervision of Professor Leonie Young and Professor Arnold Hill here at RCSI. This research won the American Association of Cancer Research Scholar in Training Award in 2011 and the Sylvester O'Halloran Prize in 2012. In 2013, he embarked on the Irish Higher Surgical Training Programme in General Surgery, focusing on upper GI surgery in his latter years, and successfully achieved his intercollegiate fellowship examination in 2020. Having successfully competed for the Collis Travelling Fellowship, he moved to the University Health Network and the University of Toronto, Canada, where he undertook a comprehensive clinical and research fellowship, and unusually for 2 consecutive years was awarded the university's F. Griffith Pearson Award for his teaching of undergraduates, residents, and fellows. Among numerous achievements during his training, perhaps the most noteworthy are his Atlantic Surgical Leadership Award that enabled him to visit the Hanoi Medical Center in Vietnam, and his role as the inaugural chair of the Irish Surgical Research Collaborative. In 2024, he was appointed to his current role as Consultant General and Upper GI Surgeon and Associate Professor of Surgery at Beaumont Hospital. Since commencing practice, he's begun to explore his long-standing interest in responsiveness to neoadjuvant therapies in esophagogastric cancer and the development of metastatic pathways. Most recently, he collaborated in the successful application to the Disruptive Technologies Innovation Fund by the Plio Surgical Project, a €3.9 million investment that will see the Beaumont RCSI Cancer Centre performing the first in-human implantation of a minimally invasive anastomotic device. In summary, I know you will agree that Professor Jarlath Bolger is a most worthy candidate to deliver the 48th Millin Lecture, and it's now my pleasure to ask him to come forward to deliver his lecture entitled Personalised Oesophageal Cancer Care, From Micro to Macro to Reality.
Uachtarán an Coláiste, Las Uachtarán, Iar Uachtaráin, Colleague Cordia agus Teilech, Táim an Bhródúil, a bheith seo agus an deis an Léicht Millin a chur láthair. Now, lanig mé ar aig as Berlin inis. But thank you. As with many Millin lecturers, when I was asked and invited to give this, I started out by looking at Sir Terence Millin and his life to see, are there any similarities between us? Terence Millin was certainly a snappy dresser, and he's pictured here with his customary cigarette in hand. I've never smoked. He was born in 1903 in Helens Bay in County Down, 100 years to the year before I started medical school. But then he relocated when he was 2 years old to South County Dublin and went on to study in Trinity College, where he was also an avid rugby player. Me, I'm not so much of a snappy dresser. I was born in Tala in southwest Dublin and went to school in the North Inner City, so not too many similarities. I'm a proud graduate of RCSI, but at least we have one thing in common. I did manage to captain Beaumont to a Hospitals Cup many, many years ago. We do overlap, however, in our interests in trying to improve surgical care and surgical standards. Millin is especially famous for his 1945 paper in The Lancet, where he describes the approach to retropubic prostatectomy. And while other surgeons in London at the time claimed that they had done it first, what was really revolutionary about Millin was that he presented his whole case series and described the technique in detail and the perioperative care. And in his case series of 20 patients, there were no mortalities. His fame grew, and by the time he published his text in 1947 on retropubic surgery, he had over 400 cases in his case series. So within a couple of years had really gathered this. And I think a lot of what Millin can be credited for is standardizing our approach to surgical technique. But what I'm going to argue today is that while standardization has been revolutionary for surgery, I hope to be able to convince at least some of you that we're in an era now where we can start to move towards personalizing our approach, both, as I said, from the micro to the macro level. So my background is as an esophageal and gastric surgeon. Esophageal cancer is unfortunately responsible for almost 500,000 deaths worldwide per annum. Mostly what we deal with are squamous cell cancers and adenocarcinomas, but in this part of the world, about 70% or 75% of what we deal with is adenocarcinomas. It's increasing, and it's partly down to lifestyle factors, increased obesity, increased reflux, and lots of people having uncontrolled reflux disease. Unfortunately, in spite of investment over the years, for all comers, we still only have about a 20% 5-year survival. But for those with resectable or curable disease, it's about 50%, and in some case series, including our own in Beaumont, we're pushing 60%. So getting better, but still room for improvement. Surgical removal of the esophagus, esophagectomy, remains the cornerstone of cure. But our survival has been dramatically improved by the evolution and addition of neoadjuvant and perioperative therapies. Now, I don't want to get too deep in the weeds on this, but essentially for patients who have potentially curable esophageal cancer, most of them now will get perioperative chemotherapy with the regimen called FLOT. Some patients will still get chemoradiation with CROSS, and if they have they've got residual disease after they've had CROSS, they might get some immunotherapy. If you've got palliative disease and you're getting chemotherapy, most of them will get some sort of platinum-based therapy as well. So platinum-based therapy still does most of the heavy lifting for esophageal cancer. We know from the trials about 20 to 25% of patients who get chemoradiation get a complete response. So we take out their esophagus and the disease is gone. 10 to 15% of patients treated with chemotherapy have a complete pathological response. But we don't know how to predict who is actually going to respond. Some of the recent trials, New Aegis, which was led by Ireland's own Professor John Reynolds, and I'm delighted that he's here this evening, compared perioperative chemotherapy with chemoradiation. And it was followed more recently by ESOPEC, specifically looking at FLOT and CROSS. But what we see from these is, when we look at the people who don't respond, somewhere in the region of 50 to 60% of patients who get chemotherapy get little or no pathological response. For those with chemoradiation, somewhere in the region of 27 to 47%. And one of the things that I'm interested in is, do these cohorts overlap? Do we just have people who have good biology and bad biology? Can we give people neoadjuvant therapy, and does it really matter what they get? Currently, we don't have any facility for switching therapies if people aren't responding, and does it really matter? As I said, have we just got good biology and bad biology? This is what our regimens look like. So if you get chemoradiation, you get chemoradiation for about 5 weeks, then you get a little bit of a break, restaging, and then on to surgery. If you get chemotherapy, you get 4 cycles of chemotherapy over 8 weeks, a bit of a break, and then on to surgery. There's a couple of little question marks in the slide here. The Sano trial was suggesting that maybe in some patients, if they've got a good, complete clinical response, we can just watch and wait. I think the data on that is inconsistent, and I think we'll know a bit more in a few years' time. The FLOT trial, about 3% of patients who get chemotherapy don't ever actually get on to surgery because of the toxicity of chemotherapy. And these are just things we have to bear in mind. But I would say in this current paradigm, we've got a relatively limited window to actually assess our treatment response and potentially change our approach for patients. But I think we can get there. As I said, it's been difficult to define biomarkers in esophageal cancer. It's a very heterogeneous and chromosomally unstable disease. High-throughput sequencing has not proven useful in this disease, and this figure is from Rebecca Fitzgerald's group in the UK. They published this in Nature Genetics in 2019, and they sequenced 530 esophageal adenocarcinomas. And essentially, outside of P53 mutations, which are very common across multiple cancers, they haven't really shown any repeated mutations. A small amount of patients have HER2 mutations, which are treatable, but nothing else targetable. So how do we test drugs at the moment? Well, in vitro drug testing is based on cell lines. Cell lines are very imperfect. They don't represent the full mutational burden of cancers, and particularly in such a chaotic and heterogeneous disease. What about patient-derived xenografts? Take some patient tumor, put it in a mouse, and see what happens. Well, PDXs are difficult to establish, they're expensive, it can be difficult to quantify a treatment response, and it may not fully map back onto the primary tumor. And particularly in an era of evolving immunotherapy, I think taking a tumor and putting it into an immune-deficient mouse doesn't really tell us very much. So this is where my interest in esophageal organoids has come from. So what are organoids? They're three-dimensional cultures that we derive from patient tumors. So we take a sample and grow it in three-dimensional culture. It's used in lots of different GI malignancies, and it does appear to be a relatively robust preclinical model. Previous work from my previous supervisor and now collaborator in Toronto, Professor Jonathan Young, has shown that in esophageal cancer, PDOs recapitulate the primary tumor both at a morphological and a genetic level. So when we look at their staining under the microscope, their H&E, it looks like the primary tumor, and when we map it back with genetics, it resembles the primary tumor. So it's a good preclinical model. So I was away in Toronto for 3 years, as Professor McNamara mentioned, and I was funded by the Collis Fellowship, which I'm very grateful for. But these are some of the questions that we were trying to answer. Does the in vitro drug treatment of these PDOs actually mimic what happens in the patients? Can we use them to predict response to other therapies when they're not responding to their induction therapy? And again, coming back to the old chestnut of does the choice of neoadjuvant therapy actually matter? So this was all done under the framework of the MOCA study, and this is just to give you an idea about how comprehensive this program is. It really does take a 360-degree view of the patient. So we were taking biopsies at their diagnosis. This is both for primary and for metastatic patients, blood at various time points, more biopsies following the resection, and blood for various surveillance time points. We were taking these fresh, frozen, and paraffin embedded to grow organoids, DNA and RNA extraction, and for H&E and immunohistochemistry. The blood we were using for cell-free DNA and circulating tumor cells. So a really comprehensive 360-degree view of the patient. But today I'm going to focus on the organoids. So what we did with these initially was we took a panel of organoids from patients undergoing curative treatment and exposed them to a panel of drugs. And the first thing we wanted to look at was the platinum-based chemotherapy, which, as I said, does a lot of the heavy lifting. Now, it can be a little bit difficult to parse anything from these concentration curves, but we split them into the responders and the non-responders. But I think you'll see when we look at the actual drug treatment metrics, the IC50 and the EC50, there's dramatic differences. So what this is telling us is for the patients who respond to their platinum-based chemotherapy, we only need a small amount of drug in the lab to induce a similar response. So this is suggesting that they're mimicking what's happening in vitro. For the patients who didn't respond to their platinum-based chemotherapy, we were having to give enormous doses in the lab to actually induce a response, and toxic doses that a patient wouldn't tolerate. And when we look at the numbers again and correlate it with the tumor regression grade, and this is from the College of American Pathologists, TRG, we can see the absolute numbers and significant differences, and again, this holds true in our correlation matrix. So, at least for platinum-based chemotherapy, the organoids are mimicking what happens in the patient. So we were delighted with this and decided to look at some of the other drugs. So taxanes are one of the other drugs that we use quite frequently in upper GI cancer, but unfortunately we didn't see the same effect for taxanes. But we got some good reasons for this. Taxanes inhibit microtubule formation and interact with the tumor microenvironment. And I think I will come back to this later on. I think part of the problem is our model and our TME in vitro is not really representing everything that we want. We went back to the platinum-based therapy and looked at metastatic disease, and again, very clear response in our metastatic patients. So what we next wanted to see was, if we treat these drugs, or treat these PDOs with drugs that aren't currently used, what happens? So we took another panel of organoids from patients undergoing curative therapy and treated them with irinotecan. So this is a topoisomerase inhibitor, not currently used as a first-line therapy in upper GI cancer, but used widely in GI malignancy. We split them out into the organoids that responded and the organoids that didn't respond based on their drug treatment metrics and their growth factors. So of those that responded, the organoids that responded, we look back at the patients then. So 4 of our organoids had a great response to irinotecan. but the actual patients had no response to their chemotherapy. One of our patients who had no response to irinotecan had a complete response to their chemoradiation. We did this again with epirubicin, which until recently was used in upper GI malignancies, and again split it into responding and non-responding organoids. 2 of the organoids that responded had no response following their neoadjuvant therapy, and 2 that didn't respond had a complete response following their chemoradiation. So this is giving us some evidence that in certain cases, we could actually switch treatments and give people different chemotherapy and potentially induce a treatment response. So can we use the PDOs as a platform for personalizing interventions? Maybe, but it needs to be repeatable and we need to be able to grow organoids on a consistent basis. So our take rate was pretty good. When we took a primary biopsy, we managed to grow an organoid 70% of the time. We weren't as good when we were taking biopsies after chemotherapy or chemoradiation, or when we were taking biopsies from metastatic sites. So we had to look back at that to see why that might be the case. And from the clinical point of view, as I said, for the post-resection or the IR biopsies, difficult to grow. The patients who are post-treatment, difficult to grow. But surprisingly, the poorly differentiated or the most aggressive tumors were most difficult to grow the organoids from. And again, when we control for all the other factors, this remains true. So why are poorly differentiated tumors less likely to establish PDOs? We're not sure, and that's something we're looking at. How can we improve our understanding of the tumor interactions with the tumor microenvironment? And in that era of evolving immunotherapy, how can we better model these interactions in the lab? And can we use these to better understand the metastatic profile of tumors? So in the last 18 months, what I've been doing in the lab is trying to set up the CLEARER study. So this is looking at the characterization of esophageal cancer and treatment responses. And our aim is really to develop better models and understanding of the interaction between the tumor, the immune system, the microenvironment, and the drugs that we use, and hopefully develop a usable organoid platform that we can bring onto clinical trials. The second arm of CLEARER then is to look at mechanisms of metastasis, particularly CNS metastasis, using the organoid platform. These are some of my collaborators, Dr. Damir Varaslia, who's a senior lecturer here in RCSI. Myself and Damir did our PhDs together many years ago. Professor Jonathan Young, who was my supervisor and now collaborator in Toronto. Professor Malinar Mugasamy, who's one of my upper GI colleagues in Beaumont. And Mr. Steve McNally, who's a neurosurgeon in Beaumont with a special interest in brain metastases. I've mentioned immunotherapy a few times, and its use is evolving. Normally, when we're looking at using immunotherapy in esophageal and gastric cancers, we look at PD-L1 status, and that will usually tell us if a tumor is going to respond or not. But an interesting phenomenon is that sometimes the PD-L1 status changes, and if so, why? So we biopsy a patient initially, they might be low, and then following treatment, they've got high PD-L1 status. Is it that the treatment is inducing change? Is it that we're exerting a selective pressure by killing some cancer cells and not others? And how can we better model this? So we really want to have a better model of immunotherapy in the lab. And that's the first kind of real aim of CLEARER. So we're in the process of getting our organoid biobank up and running at the moment. And we're going to utilize this to grow some co-cultures, put our T cells in, both circulating and peritumor T cells, to demonstrate that we can grow them together and that they are a usable model. And we're initially going to use trial doing this with Matrigel. Now, Matrigel is a very widely available and very widely used substance. It forms a simulated extracellular matrix, and that's what we're initially going to grow our things in. But the ECM media, such as Matrigel, are limited. There are other media that do a similar thing, where you can control the stiffness and that, but they're imperfect. So we know that the spatial interactions between the tumor, the microenvironment, the other cells, such as fibroblasts, such as the T cells, are really important for treatment response, and particularly for immunotherapy. And we're planning to 3D print some scaffolds using differential collagen gradients, so we can then seed our organoids into that and hopefully better model those spatial interactions in the tumor microenvironment, with the goal of developing a working model for studying our chemotherapy and immunotherapy interactions, and hopefully building a more relevant TME model. Myself and John Young in Toronto are already designing our first trial on this for the patients, but that's a little way down the road yet. The second arm of CLEARER then is looking at metastases in esophageal cancer. If you ask most upper GI surgeons about the rate of brain metastases in esophageal adenocarcinoma, they'll say it's pretty rare. But actually, for patients who recur, up to 20% of them will get a brain metastasis. And it's a slightly weird phenomenon. Those that get a brain metastasis are more likely to have had a good response to their systemic therapy, and they're more likely to have a well-differentiated tumor. This isn't just a temporal thing that these patients are living longer, and we don't know what the driver mutations or the immune escape mechanisms are. But we do know that if there's a single site of recurrence, this is potentially resectable and there's the potential for long-term survival. So this is great for patients, but also for people like me who are interested in cancer biology, because this means we can get our hands on tissue. Now, we're lucky in Beaumont that is the National Neurosurgical Centre, and they resect about 5 esophageal adenocarcinoma brain metastases per year. So we're in the process of getting matched primary and metastatic tissue from some of these patients with the intention of initially doing some whole exome sequencing and also some RNA sequencing. And what I'm particularly interested in here is the differential gene expression and the gene set enrichment analysis. And with time, we're hoping to establish our metastatic PDO model. These are really difficult to do, and there's some philosophical questions here that we need to figure out first. Do you grow your PDOs like the host organ? So if you've got a brain met, do you grow it like you would some brain tissue? Or like the originating organ, do you treat it like you would some primary esophageal tissue? So we're trying to figure this out at the moment. Where are we at? Well, we've got nearly $500,000 in funding to date. Our first MD student is in situ. This is Dr. Jack Logue, and I just want to pay tribute to Jack. He's done an enormous amount of work over the past 5 months in getting this up and running. I think keep an eye on Jack. He's got a very bright future ahead, and who knows, he may be standing up on this podium one day giving the Millin lecture. We're in the process of hiring our research assistant, hopefully someone in place before Christmas, and we will be advertising shortly for our postdoctoral researcher. I would just like to acknowledge that we've had great success with funding. We've had a very large philanthropic donation, which has come through the Beaumont Hospital Foundation, some seed funding from RCSI, and from the Beaumont Hospital Cancer Research Trust, and I just want to acknowledge and thank all of those funders. So that's some of the micro. What about the macro? Well, as I said, esophagectomy is still the cornerstone of our treatment for curable cancers. In the 1980s, in-hospital mortality for esophagectomy was often reported at about 15%. So really high. 1 in 6 patients goes in for an elective operation and don't make it out of hospital. But centralization and standardization over the last number of decades have massively improved outcomes. Up until recent years, most of what was done was open esophagectomy. And again, if we look back at the CROSS trial and Professor Reynolds' NeoAegis trial, most of these patients had an open operation. But there was lots of complications. About 40% of patients had a chest complication. Up to 20% of patients have a cardiac complication. In the CROSS trial, up to 30% of patients had an anastomotic leak, which is really high, much better in NeoAegis at 11%. And the 30-day mortality was still high in CROSS at 7%, much better in NeoAegis at 3%, but up again a little bit in ESOPEC at about 4 or 5%. And if you did come from an esophagectomy, this is the kind of thing you'd see. Laparotomies, thoracotomies, lots of intensive care unit usage, and it was really a big morbid operation. If you come for an esophagectomy in Beaumont now, this is likely what's going to happen. You're going to have a minimally invasive operation using the robot. We know that the minimally invasive operation does improve outcomes, and this is a paper we published in Beaumont a number of years ago. We looked at about 269 patients undergoing esophagectomy and looked at their textbook outcomes. Textbook outcomes are a composite metric that makes up a number of different perioperative outcomes. So things like not having postoperative complications, not having intraoperative complications, ensuring that you have an adequate lymphadenectomy. And we saw that the patients who had a textbook outcome had improved long-term survival. But not only that, when we added in a minimally invasive approach as a textbook outcome, they actually did a further increase in their median survival. So this is telling us what happens in the perioperative period matters. So what about evolving then onto the robot? Well, we're lucky that Beaumont has Ireland's first robotic esophagectomy program, and I just want to pay tribute to my colleague, William Robb, who set this up, and he performed Ireland's first robotic esophagectomy in 2020. And our rates and our numbers are going through the roof. This year we're on course between esophageal and gastric resections to hit triple figures for the first time. Now, I'm not going to do too much in terms of showing videos, but I will just show you one short video just to give people a flavor of the dexterity and some of the things we can do with the robot. So this is just doing some abdominal lymphadenectomy. This is looking up towards the patient's hiatus. And we can see that we've used our robotic instruments to really skeletonize the vessels here, do a really nice lymphadenectomy. We're clipping the left gastric artery here, and we can see the common hepatic and the splenic artery fully stripped of lymph nodes and tissue. And yes, you can do this laparoscopic or open, but it's easier with the robot. We can operate in the chest. We can use chromatophores to do nice things like identify the thoracic duct to allow us to clip it. And for all GI surgeons, we're all obsessed with our anastomosis. So this is looking up into the chest. We've pulled the stomach into the chest, and we're just anastomosing it on here, doing a nice stapled side-to-side anastomosis onto the esophageal remnant, and then using our robotic platform, a really nice, easy way to close our defect using a couple of running V-lock sutures. So this is the kind of thing that we can do with the robot. Does it improve outcomes? Well, we've just published this. And if we look back at our first 100 cases, we've seen a dramatic decrease in our anastomotic leak rate, so down to about 4%, which is very competitive looking at other international centres. We have seen an increase in chyle leak rates, and we've got a good reason for that. I think we're being more aggressive in the chest in terms of our dissection and getting margins. But I would also say that we've introduced, started and launched a randomized controlled trial to look at how we're going to manage that and decrease that. A trend towards reduction in respiratory tract infections and a significant reduction in our ICU utilization, which is really important for patients. And furthermore, we're seeing more patients getting a textbook outcome. And hopefully we'll be able to demonstrate that long-term that this translates into improved survival. So that's some of the standardization, but this is supposed to be about personalization. In esophageal cancer surgery, there is lots of dogma in perioperative care, and the evidence is often lacking. I was at the Orgis conference in Glasgow last month, and there were debates on all of these topics. Lots of people had very strong opinions, but not too much data to back up their opinions. So the use of NG tubes, the use of feeding adjuncts, pyloric procedures, long-term surveillance, lots and lots of debate, not too many answers. In the interest of time, I'm going to just focus on two of these things and give a little flavor of some of the research we've been doing. So, pyloric procedures. Conduit dysfunction is very common after esophagectomy. So we turn the stomach into a tube and pull it up into the chest as a neoesophagus. As part of that, we divide the vagus nerves, which provide innervation to the stomach. So it's slow to empty in the initial postoperative period. It improves with time. We know that by 6 months, about 70% of the pacemaking function comes back. And by 1 year, if it's going to come back, you get to about 80 or 85%, and your stomach works better and empties as it should. But in the short term, there are strategies to improve emptying. Lots of surgeons advocate doing a pyloroplasty, so dividing the pylorus, the muscle that drains the stomach, doing a pyloromyotomy, just dividing the muscle and leaving the mucosa intact. Some people doing open operations still do a finger fracture, so they put their hand in and rub the pylorus to try and break down the muscle tissues. Or you can do an endoscopic dilatation and Botox it. These all work, and in the postoperative period, you can drain the conduit really well into the small bowel. But the problem is long-term, you can induce more dumping syndrome. Dumping syndrome is a really horrible thing for patients to deal with. Every time they eat, they can get flustered, they get sweaty, they get palpitations, a little bit like me before this lecture. We do know that, so we looked at this in Toronto, and for patients that we don't do a pyloric intervention on, what happens to them? About 25% of those patients will need something done to their pylorus eventually, most of them an endoscopic dilatation, which is an easy thing to do, and occasionally a reoperation. Interestingly, the earlier stage patients, so who had less dysphagia, are more likely to require dilatation. But I think when you kind of sit back and think about it, it makes sense. The patients who weren't struggling with swallowing beforehand, all of a sudden they're feeling full, they have a bit of difficulty swallowing, and they need some help emptying their conduit. So we want to think, are there ways that we can better measure this and potentially intervene on an individualized basis? The endoflip impedance planimetry system is it's actually a piece of Irish technology manufactured by a company out west. If you haven't used it, it's really useful for when you're doing endoscopy. It's a small probe you can put down beside your gastroscope and then inflate a balloon across a sphincter. It gives you dynamic feedback on the distensibility, the pressures, and the diameter of the sphincter. It is routinely used by some people in anti-reflux work, in dealing with motility problems, and in sphincter assessment, but it hasn't been used in this context before. So what we did was just a small prospective observational study. We took 20 consecutive patients undergoing esophagectomy, and at the end of their operation, we always check their anastomosis with our endoscopes. We pop the endoscope down to make sure our anastomosis is intact and do a leak test. For this, we also put down our endoflip probe and put it across the pylorus. We took measurements at various different volumes of the balloon and put that away, and then came back a year later to see how many patients actually needed a pyloric intervention. It's a small study, but in this study, 50% of these patients required something done at some point. And the most common reason was that subjective feeling of delayed gastric emptying. There was no difference between those that did and didn't in age, stage, ECOG status, smoking, diabetes, or their surgical approach. But what we did see was when we inflated our balloon to 40 or 50 mils, we did see a difference in their distensibility. So the stiffer, less distensible pylorus may be more likely to need intervention. So this gives us some evidence that we may be able to select out those patients that may need something done to their pylorus and do it at the time of their primary operation rather than waiting until they run into trouble. We're in the process of designing a trial to do this, and again, this may be using endoscopy and biopsy and a dilation of the pylorus, but it may also be doing an endoscopic pyloromyotomy if we can. What about other bits? And one of the other things we were looking at was follow-up of patients. Any of us who worked through the pandemic know that COVID forced huge work practice changes on all of us. Virtual outpatients talking to patients on the phone, over MS Teams became a normal option. We think some of the restrictions in Ireland were severe. Well, I can tell you they were even more severe in Canada, and it was difficult for patients to get to the hospital for their standard post-operative appointments. So lots of these patients were followed virtually after having had major resectional surgery. We wanted to know, was this safe? So we had a very talented pre-medical student who looked at this. And what we saw was that it was safe. Their emergency admissions were similar or improved compared to our in-person cohort. We had slightly more usage of our endoscopy, but we were using that because we had patients on the phone. They tell us they had a feeding tube problem or a bit of dysphagia. We could bring them directly to endoscopy to assess them. So it is safe, and that got us thinking, this whole surveillance of patients, can we do it better? And can we even, exclude some patients from surveillance if they need it? So surveillance is a time of huge anxiety for patients, trying to think, is my cancer back? And if it is back, is there anything that can be done about it? And believe it or not, we don't have standardized protocols for imaging and endoscopic surveillance after this big resection. So in Canada, we overdid it. We probably, I suspect, we scanned patients every 3 months for the first 2 years. And that's one end of the spectrum. At the other end of the spectrum, until recently in the NHS, they didn't recommend any radiologic surveillance for patients with esophageal cancer. And I think we need to think, what's the purpose of surveillance? Is it to reassure patients? Is it to pick up recurrences? And if we do pick up recurrences, are we any better at treating them? I think we are. We've got new therapies coming on stream. We've immunotherapies. We're better at radiation therapies. And we're evolving in esophageal cancer to where we're actually considering metastasectomy in some patients. So it's worth picking them up. But for patients who don't recur, it's a lot of stress. So we looked at the factors that are associated with recurrence, and it's all things that we know about. Patients with a higher pathological stage, patients with poor response to their neoadjuvant therapy, with a high lymph node ratio, so lots of lymph node disease, and high-risk histology features. Surprisingly, the younger patients were more likely to recur, and again, once we controlled for other factors, this stayed true, so it's, again, not just a temporal thing. And those patients that do recur, they recur in the first 2 years for the most part. So that's when we should be intensively surveilling some patients, but are there other patients we can exclude? So we put together an algorithm based on this. And these are just hypothetical results, but for this patient cohort, if you look at the algorithm and exclude patients who have only one of these high-risk features, you can take 23 patients out of surveillance. So 12% of the patients, they go out of surveillance and we don't miss any recurrence. We broaden it to 2 of these risk features, then all of a sudden we're about halving the amount of patients who need surveillance, but we're starting to miss recurrences at about 16%. If we loosen it further and exclude patients with 3 of these features, again, we're excluding more than half of our patients, but we're missing more recurrences. So we're in the process at the moment. We've published that in EJSO this year, but we further work ongoing to try and improve the accuracy of our algorithm and model, and also look at the quality of life implications and look at the cost implications. But I think it is likely that we can reduce the surveillance burden for some of these lower risk patients using personalized risk assessment. So micro to macro to reality, I think it's worth leaving the question mark there for now. But I hope I've shown you this evening that using patient-derived tissue, we can improve our understanding and modeling of response to therapeutics with the goal of personalizing therapies. With technological advances, we can better tailor our operative and post-operative approaches based on patient physiology and their cancer risk. And I think we do have the potential to move care from a universal, standardized approach to a more personalized precision approach. Now, if you'll indulge me for a couple of minutes, there's lots of people that I just owe some thanks to for all of their support in getting to this point of my career. And this stretches right back to when I was an intern in Beaumont Hospital with Professor Bro and Dennis Collins way back in the day. As Professor McNamara mentioned, I then went on to do my PhD in RCSI with Leonie Young, and my still in touch with other colleagues there, such as Demir, Sinead Kokilia, and Fiona Bain. Those who trained me then on the National Surgical Training Scheme as an SHO, my colleagues in Beaumont now, Colin Power and Mike Allen, and in the matter, my brief stint in orthopedics, Keith Sinnott and Seamus Morris. I then had what I like to call my Wild Atlantic Way years. Some time down west with Ronan Waldron, Kevin Barry, Wakar and Iqbal Khan. I had a tremendous year in Kerry with the late Brian Waldron and particularly with Kevin Murray. And I just want to pay special tribute to Kevin Murray. He taught me a lot about surgery and life, but also taught me a lot about marathon running, and that's most important. My last stint on the Western Seaboard, I want to pay particular tribute to Calvin Coffey and Colin Pearce. They've been huge supporters of mine, and I was really lucky when I was there to be one of the first trainees in the country to be given access to robotic training and be one of the first trainees to actually do some robotic resections on the console. Back to Beaumont, my upper GI colleagues, Will Robb and Mylan Armugasamy, they've both been enormous supporters, mentors to me over the years and now colleagues. my time in the Mater with John Keneally, Jerry McEntee and Anne Brannigan, which was a tremendous year in spite of COVID. And then my final year training in Ireland with John Reynolds, Ravi and Claire out in St. James's Hospital. My time in Canada, I again want to acknowledge all my supervisors there. I learned a huge amount, and I hope I've brought something new back to Ireland from Jonathan Young, Gail Darling, Elliot Wickham, Tim Jackson and Alan O'Cranick. And now, back in Beaumont, I just want to thank my general surgery colleagues, John Burke, Niamh McCauley, Brenda Murphy and Abida Butt. I also want to thank the RCSI, and I want to particularly thank Professor McNamara for all of your support over the last 2 years. It's been really helpful to me in terms of getting set up and everything that I'm trying to achieve with the research group. Professor Cathal Kelly and Professor Fergal O'Brien, who are both here as well, who've been enormously supportive of me as well. I'd like to thank our upper GI cohort and clinical nurse specialists and dietitians in Beaumont. They really do run a world-class service. And I'd like to acknowledge all of my funders over the years and all of my trainee colleagues in the Irish Surgical Research Collaborative over the years. It's in really safe hands and they're putting out some brilliant research now. I want to pay special tribute to these two people, Michael Kelly and Christina Fleming. So these are the past two Millin lecturers. Michael and Christina have both been great friends of mine for over a decade now and have given me huge advice in preparing for today. It's also an interesting phenomenon. We've now had 3 consecutive Millin lecturers from the same SPR cohort. And I would just say to the others from our SPR cohort ahead of next year, no pressure. Now, there's one person who is conspicuous by their absence from this slide, and he's probably shifting uncomfortably in his seat, wondering if he's going to make an appearance, and that is, of course, Professor Arnie Hill. I just want to take the chance to publicly thank Arnie for all of the support over the years. He's been, right back from when I wrote my first paper as a medical student, a mentor, a supervisor, a trainer, and in more recent years, a colleague and a friend, and I really appreciate everything, Arnie. Before I finish up then, I just want to thank my family, my parents, Liam and Bridget, my in-laws, John and Mairead, my brother Eamon, who in recent years has retrained as a medical statistician, which I can assure you is very helpful. But also then the people closest to me, my lovely children, Hannah and Elliot, and my wife, Marie Bambrick. So it has been an absolute honour and pleasure to present the 48th Millin Lecture. Many thanks.
So I think we've had a truly excellent Millin lecture this evening. Congratulations on all that you've achieved so far, and I look forward to the contribution you'll make to Irish surgery in the future. And it's now my honour to give you the Millin Medal.
Congratulations, Professor Bolger, on an outstanding lecture in the best traditions of the Millin lectureship. That concludes the formal aspect of this evening. We'd like to invite our audience to join us for a reception downstairs in the atrium. And if I could ask you to please be upstanding for the outward procession. Thank you.